Oh. Good evening, Dr. Naraj. Good evening.
Sir, good evening, sir. Good evening, sir. Thank you, sir, for very much joining for this session, sir.
Fine, fine.
And
good evening, Parliament, sir.
Oh, sir. Good evening, sir. Good evening. How are you, sir? Fine, fine.
Fine,
Nice.
fine, sir. How are you doing, sir?
Nice to meet you. Yes, madam also.
Yeah. Yes, sir. Good evening, Natarajan, sir.
Yes, madam. Good evening.
yes, sir. Good evening, sir. Saram, sir. Good evening, sir.
Yeah.
Happy to have, sir.
Yeah.
And Alagami, madam. Madam, welcome, madam. Welcome to this session.
Thank you, sir. Thank you, sir. Thank you, sir.
Good evening,
everyone.
Dr. Alagami, madam.
Good evening, sir. Good evening.
Good evening.
Thank you, sir.
Yeah.
We will start, sir.
Yes, sir.
Start, sir.
Sir, and first of all, I thank the API for giving our Tiruvallur Medical College this opportunity to hold this PG master class. And I thank particularly Saravanan sir and Palaniappan sir for their continuous support. And especially thanks to our former HOD and expert in the field of medicine, Dr. Parandaman sir, who is a very good teacher. And we expect a lot of things from Parandaman sir. And I thank once again Alagami madam, is a very good gastroenterologist from Meenakshi Hospital, Madurai. She is one of the finest gastroenterologists I have ever seen. Thank you, madam. Thank you for accepting and joining this session.
Thank you, sir. Thank you for the invitation, sir.
Yes, madam. And my PG, PK Balaji, who is a final year postgraduate, will be presenting a case of DCLD with complications, madam.
Okay,
And
sir.
Balaji?
Sir.
Sir? Balaji, okay. You can start. You just switch on your video also, Balaji. After that, you can close.
Yes, sir.
Okay, Balaji, you start your presentation, Balaji. Start
Yes,
your
sir.
presentation. Okay.
Good evening, sir and ma'am. Today I'm going to present a case of decompensated liver disease. A 45 years male, Mr. X, farmer by occupation, brought to the Government Tiruvallur Medical College with the chief complaints of abdominal distension for 50 days, complaints of yellowish discoloration for the past 50 days. History of presenting illness. A patient was apparently normal before 50 days, after which he noticed abdominal distension, which was insidious in onset, gradually progressive to attain the present state, which was uniform in distension, which has got no aggravating and relieving factors. He has also had a complaints of yellowish discoloration of eyes for the past 15 days, complaints of passing eye-colored urine for the past 50 days. Then history of loss of appetite for the past 2 months, history of sleep disturbances for about 2 months. Then there is no history of abdominal pain, no history of fever, no history of bleeding manifestations like gum bleeding, hematemesis, melena. Then no history of breathing difficulty. Then no history of chest pain, no history of palpitation, no history of decreased urine output, no history of puffiness of face. Sparse history, he has got no medical comorbid conditions like systemic hypertension, type 2 diabetes mellitus, coronary artery disease, COPD, and epilepsy. There is no history of past surgery, no history of similar complaints in the past, history of native medicine intake at Paravai before 2 weeks, no history of blood transfusion in the past, history of tattooing in the present. Tattooing in the past.
Balaji, you said many past history. For
Yes,
what
sir.
did you ask this past history? Just give a word about it, each and every past history.
If the patient has got systemic hypertension as well as type 2 DM, then we can suspect it. Then we can suspect metabolic dysfunction associated steatotic liver disease. If the patient has got because of the history of a native medicine intake, the native medicine itself, some herb itself is an hepatotoxic substance, as well as the native medicine which has got which has got an addition of heavy metals like mercury, which has got an hepatotoxic effect. Since with the history of tattooing in the past, there may be the chance of transmission of hepatitis B viruses in the past, which can lead into a chronic viral hepatitis, leading into a cirrhosis, leading to the manifestation at present. Because of the history of blood transfusion, even in the blood transfusion, hepatitis viruses can transmit, leading to a viral hepatitis, a chronic leading to chronic viral hepatitis, leading to a cirrhosis, leading to this present status.
Okay, Balaji, before the past history, you tell me where is the problem, what is the problem, how the problem started, what could be the likely cause for the problem. With the history, is there a problem? Am I audible?
Sir, I'm not I'm not clearly able to hear, sir.
Oh, yeah. What is the problem? How does problem start? Is there a problem, first of all? Is there a problem? Where is the problem? And if at all problem, what could be the problem? And what is the cause for the problem? See, with the history itself, you should tell all these things in the history itself. So now you said loss of appetite 2 months and sleep disturbance 2 months. This preceded the abdominal distension, jaundice.
Yes, sir.
You tell me the condition where abdominal distension and jaundice all will start on the day one itself. Tell me the condition.
Abdominal distension and jaundice.
Yes, there should be some symptom preceding
Yes, sir.
other. If at all any disease, you tell me the condition. Any disease can present with abdominal distension and jaundice on the day one itself. Is there any condition like that in medicine? No, you only don't know.
Yes, sir.
You told abdominal distension 2 months, jaundice 2 months. Is it possible to have both together 2 months? That is, nothing preceded the other.
Sir, it can be of the patient gave the history like that only, sir.
No. See,
But as such, the abdominal distension can followed by a jaundice, or else the jaundice can followed by a abdominal distension, sir.
Yeah, I tell you one thing.
Yes,
Second
sir.
thing. Now, okay, leave alone the abdominal distension, jaundice.
Yes,
You
sir.
said the sleep disturbance 2 months and the loss of appetite 2 months. You
Yes,
tell me
sir.
the condition where sleep disturbance 2 months and loss of appetite 2 months causing abdominal distension and jaundice. What is the age of the patient? I'm sorry, I do not see that age of the patient. What is the age
45 years male, sir.
You tell me the condition. 45-year-old male presented with loss of appetite 2 months and sleep disturbance. Which condition which produce a loss of appetite 2 months and sleep disturbance 2 months and causing the abdominal distension and the jaundice 2 months? There is 2 months and this 50 days.
Yes, sir.
You tell me how.
Because of the chronic alcohol injection, the patient has developed steatosis followed by steatohepatitis. Initially, the patient may be in a compensated phase of.
No. I am not asking the pathophysiology, alcohol liver disease. I am not asking.
Okay, sir.
Tell me the condition where it will produce the sleep disturbance and loss of appetite, followed by jaundice together on day one itself. So nothing is matching. There is some problem. That is what important. So whenever you take history, yes, I understand that the complaint should be you have to tell whatever the patient says from his own words. You have to describe. That's
yes, sir.
That is the. At the same time, there are some people who are not educated. There are people highly educated. There are people describe right from the 10 years or of the age it's described. So what is an idea of presentation is the way you present, it should lead to the diagnosis and further evaluation and treatment. That is an idea. So probably there's something is missing. So if at all a patient develops altered sensorium or sleep disturbance, what could be the cause for the sleep disturbance?
The patient may develop an hepatic encephalopathy, sir.
That's what. No, how can they develop hepatic encephalopathy 2 months prior to before the jaundice? You said abdominal distension jaundice only 50 days, but you say sleep disturbance 2 months. So how can they without jaundice? How can they develop hepatic encephalopathy? Get the point?
Okay, sir. Yes, sir.
Means you are not analyzed it. And don't worry, I'm not demotivating you. But what
Okay,
you
sir.
need, physician, you should analyze each symptom. So yes, I understand. Probably you would have had similar symptoms and hepatic encephalopathy like this. That's why you said there is a decreased appetite. All this. So nothing is magic. With this presentation, no one can conclusive about or make a diagnosis of hepatic encephalopathy or whatever it is, organ-induced liver disease, because the history is bit it is nothing correlating. So whatever you say, you always tell what are the basic complaint, that is chief complaint you admitted for, and what was the previous complaints prior to that. Then you take the pathology right from the day, that is in ascending order, and tell what is the progression now, and you tell the condition. Only then you can localize the pathology, you can localize the etiology, then you can formulate the treatment. So the history is very important. This is a confusing history. With this history, definitely no one can make a right diagnosis, because nothing is. So, like example, no. Suppose if we have Budd-Chiari syndrome, yes,
sir.
that can have abdominal distension, jaundice together. Again, at one will precede the other. It's not that day one abdominal distension, day one jaundice. Is not possible. So at least by weeks or days, one should precede the other. So when you take the history on describing history, you should take, so which preceded, what was the first symptom, and how it's progressed. Then what is the next symptom? How it's progressed? Was there in between any symptom, or in between, like that you have to take, so that you can take the course of the disease slowly.
Okay, sir.
Then you can come arrive at the diagnosis. Everyone knows it. Probably you'll be discussing only the alcoholic liver disease, or not at a non-alcoholic liver disease, or some cirrhosis related to unusual causes. That's all. Nothing else is going to be discussed more than this. But the way you take the presentation should leads to the etiology diagnosis, pathological diagnosis, progression of the disease, complication of the disease. All these things should lead to, right? Okay.
Okay, sir.
What now? You tell me now. You said that there is hepatic encephalopathy. You're probably alcoholic. Probably that is what you are going to mention about it, and how this encephalopathy, whether it's the first episode or improved, or it is a fulminant hepatitis, or it is subacute hepatitis, acute hepatitis, or chronic hepatitis. Where you fit this?
Can I ask one?
Yes, please, madam. Please, madam. Yes.
What is ACLF? What is ACLF?
Acute on chronic liver failure, ma'am.
So, what is the classical history of a patient presenting with ACLF in an alcoholic? Classical history.
Ma'am, with the prior history of liver disease, when the patient presenting with the symptoms of coagulopathy as well as encephalopathy, we can term the patient into an acute and chronic liver disease, ma'am.
Acute and chronic liver disease, acute and chronic liver failure has got a definition where there is an underlying CLD, chronic liver disease, whether it is known or unknown to the patient, whether it is having a documentation in the past or not. If there is a chronic liver disease, and if there is an acute insult happening on the top of chronic liver disease, the liver will tend to fail immediately because there is no reserve. So it will tend to fail immediately. So jaundice and ascites coming together can happen only in ACLF, not in DCLD. Decompensated chronic liver disease is a gradually progressive disease where decompensation happens one after the other. They don't happen at a time. So somebody is developing jaundice and ascites similar timing. Maybe jaundice followed by ascites within a few days or 1 week or something like that. The underlying chronic liver disease superadded alcoholic hepatitis adds on, and this leads to decompensation of the liver. So by definition, if I have to tell the definition, jaundice with bilirubin of more than 5, along with coagulopathy with INR of more than 1.5 in a patient who has underlying chronic liver disease, which leads to ascites and or encephalopathy within 4 weeks of onset of jaundice. This is the definition of ACLF. This is the definition. So suppose a patient is having alcoholic hepatitis, this leads to jaundice. In the background of chronic liver disease, this leads to acute worsening and this lands up in ascites. So probably this patient had 2 weeks of loss of appetite and sleep disturbance. That means this patient had alcoholic hepatitis that started 2 weeks back. Probably he didn't notice a yellowish discoloration of eyes. Probably the 2 weeks preceding symptoms indicate that the alcoholic hepatitis has started 2 weeks back. In the background of cirrhosis, this has led to decompensation in the form of ascites after about 2 weeks of onset of alcoholic hepatitis. After the onset of ascites, he would have noticed yellowish eyes. So yellowish eyes would have started early. After the onset of ascites, you would have noticed. So
Patient
that's
may
why
not
the chief
notice.
complaints. That's why the chief complaints is 2 weeks. So everybody is much worried about a distension. Immediately they can notice. Whereas yellowish eyes, unless the relatives note, he may not see. Particularly if he's an alcoholic, he will keep drinking with jaundice. So probably this patient has come with acute alcoholic hepatitis in the background of chronic liver disease, which has led to ascites. The sleep disturbance, you should have explained what is a sleep disturbance. Because in hepatic encephalopathy, the sleep disturbance which is classically explained is daytime sleepiness and generalized lethargy and dullness. Whereas an alcoholic can have sleep disturbance just because of not taking alcohol for a day. He will have insomnia, he will have withdrawal symptoms. So he will have decreased sleep because he wants to take alcohol. So you should describe what the sleep disturbance is. Generally in ACLF, hepatic encephalopathy doesn't precede jaundice. Jaundice followed by ascites and or encephalopathy is the definition. So generally you don't see hepatic encephalopathy before the onset of jaundice in ACLF. Whereas in DCLD, anything can happen.
Yeah, that's one thing. Second, yes, madam. This and Balaji, how do you say? Suppose if it is a viral hepatitis,
Okay,
viral,
sir.
what is the usual presentation of acute viral hepatitis? Forget
The
about
usual,
forget about alcohol.
the presentation, the patient may have a fever, abdominal pain, with or without jaundice, sir.
No, the yellowish discoloration
Discoloration.
precedes jaundice. Typically they give history, fever,
Yellow urine,
yellowish urine, then
and
jaundice.
then only jaundice.
Jaundice.
By the time they develop jaundice, the fever subsides. That's a very typical process. See, you're a clinician. Let it be an alcoholic man. If alcoholic man develops viral hepatitis, that's a typical symptom. The fever followed by high colored urine, then jaundice. By the time they develop jaundice, the fever subsides.
Fever
That's
subsides.
a typical viral hepatitis. That's one thing. Suppose, in spite of the jaundice, patient continue to have fever. What is it? He had a fever, jaundice. Now, suppose the viral hepatitis, as the fever comes, jaundice develops, he's supposed to develop stop fever. But now fever is again coming. What is the likely cause?
Complications.
Huh? Then something. No, there are conditions, situations we are getting clinically, no.
The patient developed spontaneous bacterial peritonitis or any kind of
Fix
underlying.
to the alcoholic hepatitis and spontaneous bacterial varicose bleed and all encephalopathy. I am telling the scenario where short duration, 2 days, is a malaria. Malarial jaundice, despite jaundice, the fever keep on coming until you treat malaria. Right. Suppose a person who develops fever, jaundice, and it's not a malaria. You develop a renal failure. What is it?
We can think it of leptospirosis.
Yes, leptospirosis. Now leptospirosis ruled out. Leptospirosis is not there. What is it?
Fever, jaundice.
Harmless infection. Scrub typhus.
Scrub typhus.
Yes.
Yes, sir.
So no, you said now you are discussing about the encephalopathy to start with. That is the problem here.
Okay, sir.
There are so many details you will get, even though it's alcoholic. So you have to take the examiner slowly to your diagnosis. The way you present should lead to the diagnosis, and no examiner should not interfere with the presentation. So that smooth should only then it will come to the level of good presentation. Fine, proceed. Madam, madam, please, madam.
No, sir.
Let him proceed. We'll discuss.
A person is
decreased for this loss of appetite, sleep disturbance. 2 months or 2 weeks apart. 2 months.
2 months, sir.
That is what the problem is. See, this is madam. 2 months loss of appetite, but 50 days of problem. 2 months sleep disturbance. Is it due to hepatic encephalopathy?
No, sir. Actually, the symptoms has.
That's what. So you could have withdrawn alcohol, or somebody stopped alcohol. So you would have developed withdrawal symptoms, sleep disturbance. Again, you would have started taken. That's why the history is very important. So if you put in a diagnosis, different etiology. Whatever you are supposed to diagnose should not come. We do not come to this level. Yes, proceed.
Okay, sir. A personal history, he consumes mixed diet, history of loss of appetite for the past 25 days, history of passing eye-colored urine, history of sleep disturbances, he consumes alcohol for more than 50 years, about 180 ml of brandy per day, which is about 28.8 units of alcohol per day. Family history, no similar complaints among the family members. Sir?
1 unit of alcohol, how many grams of alcohol? 1 unit of alcohol, how many grams?
One unit contains 8 grams of alcohol, sir.
Okay, 8 to 10 grams. Some book says 12 grams. Okay, all varies. So, what is the importance of the gram?
Because whenever when a woman who consumes more than 40 gram per day, or a men who consumes more than 50 to 60 gram per day, may land up into an alcoholic hepatitis, sir.
Listen, why the women less dose itself produces cirrhosis? Why men take more dose?
Because of the the enzymes that is metabolizing the alcohol, which has got the
What enzyme? Enzyme means what, man?
alcohol dehydrogenase enzyme, sir.
What happens to a female? What happens to male?
The male has got more amount as well as more sensitivity towards metabolizing the alcohol when compared with the female, sir. As a result, the female require a little amount of alcohol to produce a cirrhosis, sir.
No. See, when you consume alcohol, alcohol is converted to acetaldehyde by alcohol dehydrogenase.
Yes, sir.
Acetaldehyde converted to aldehyde dehydrogenase, converted to acetaldehyde.
Acetate.
Okay. So what happens in females? The gastric enzyme is less. The gastric alcohol dehydrogenase is less. So what happens? It is not metabolized. If suppose 50% is metabolized in the stomach itself. So only 50% reaches the system, the circulation, serum. Here, these ladies have less amount of alcohol dehydrogenase. So the more concentration go to the blood. When more alcohol dehydrogenase is there in the blood, then converts into acetaldehyde. Acetaldehyde is a toxic substance.
Yes, sir.
That's the reason why the female get, right? Okay, then what is?
Family history, no similar complaints among the family members.
No family members. Okay.
From the above history, a 45-year male present with the complaints of an abdominal distension, yellowish discoloration of urine, with the passing of eye-colored urine, yellowish discoloration of eyes, passing eye-colored urine for about 25 days, with the history of sleep disturbance, with the background of history of a chronic alcohol intake. The probable system would be the abdomen, and the probable diagnosis would be the decompensated liver disease, probably ethanol-related with hepatic encephalopathy, ma'am.
Okay. So, we say decompensated liver disease. Actually, most of the time, right from the day one, I observed all the examiners, they don't agree with the diagnosis of decompensated liver disease. Clinician, you should say acute liver disease, chronic liver disease, or acute on chronic liver disease, or you say cirrhosis liver, portal hypertension, and complications. See, that means you are very clear where you are. Suppose you say portal hypertension, cirrhosis liver, portal hypertension. That means liver is shrunken, spleen is enlarged, acid is there. You make a diagnosis of cirrhosis liver, portal hypertension. Suppose you have a patient with jaundice. That is liver is failure, so you get jaundice. Or suppose bleeding manifestations or the coagulopathy, that means acute liver cell failure. If it's a chronic, all the signs of manifestations of chronic liver cell failure, you can say chronic liver disease. So you are a clinician, you are not a laboratory man to say decompensation. Where is the decompensation? It may be a synthetic decompensation, metabolic decompensation, it may be production decompensation, so many decompensations. It's a vague terminology. So please avoid the term decompensated liver disease. You probably in practice you can write, but a clinician, but not in the examination. No examiner agreed. I have observed almost all the examiners. What I have seen, they don't agree with the decompensation, but you should have to mention where is the problem: acute liver cell failure, acute liver disease, acute on chronic liver disease, then cirrhosis liver, portal hypertension with the complications. Like that, you have to be very specific. That's one thing. Okay. Second, ethanol related. You said okay because it's chronic alcoholic, so ethanol related, right? So hepatic encephalopathy. Do you think this alters sensitivity to hepatic encephalopathy?
It can be either due to an alcohol withdrawal also, sir.
Yeah. Alcohol withdrawal, sometimes sleep disturbance, insomnia due to so many other reasons, depression, so many things are there. Probably at this stage, at this point of time, you cannot include the hepatic encephalopathy because if we say, suppose a person who had jaundice, abdominal distension together begin with, then subsequently developed last a few days developed drowsiness or encephalopathy, things like presentation. Probably you can include as a hepatic encephalopathy. But here this started 2 months earlier to the problem. So probably that you have to remove the hepatic encephalopathy. Related you agree. Chronic, you put it as because it's jaundice. Why you put a chronic liver disease? You put acute on chronic liver
Chronic
disease.
liver disease.
Jaundice and abdominal distress is there. So you put it on as a clinical diagnosis, acute on chronic liver disease. Probably ethanol induced. You will remove the encephalopathy because it is no feature suggestive encephalopathy here due to alcohol, right?
Okay, sir.
What is the criteria to make a diagnosis of hepatic encephalopathy? Do you know the name of the criteria?
Yes, ma'am. We have got two criteria, which is West Haven criteria as well as Sony criteria, ma'am.
West Haven, can you tell what is West Haven? Do you think this patient fits into any of the West Haven's criteria to call it as hepatic encephalopathy?
Ma'am, probably the grade 2, the patient has got an increased daytime sleepiness or the sleep-wake cycle is altered, ma'am.
That is in grade 1.
Grade 1.
Grade 1 is only sleep disturbance. Grade 2 is disorientation. Disorientation. So generally you make a clinical diagnosis of overt hepatic encephalopathy only when it is grade 2 and above. What is covert hepatic encephalopathy?
There won't be no asterisks, as well as the metabolic parameters will be normal, which will be diagnosed only with the help of that psychometric test, ma'am.
Otherwise called minimal hepatic encephalopathy.
Minimal hepatic encephalopathy, ma'am.
So grade 1 also will not have flaps. So grade 1 minimal hepatic encephalopathy little difficult to differentiate unless you properly evaluate the higher motor functions. So grade, that is why it is subjective. So a patient is said to have hepatic encephalopathy only when the patient fits to grade 2 or more. So your patient as per history is not fitting into grade 2. So I don't think you have to encourage a diagnosis of hepatic encephalopathy as the complication. So you should not. So whenever you tell diagnosis, you have to give syndromic diagnosis, etiological diagnosis, and the complications. And finally, the comorbidity. So every diagnosis should have 4 components. So here the syndromic diagnosis is, as Sir said, is it acute or chronic liver disease? So probably the acute is an acute alcohol-associated hepatitis, and the chronic is also alcohol-related chronic liver disease. Probably. And then second is etiology is alcohol. And then complication. The patient is having complication in the form of jaundice and ascites. Jaundice and ascites are actually decompensations. So jaundice and ascites, and with no comorbidity. So every diagnosis should have syndromic diagnosis, etiological diagnosis, complications. And comorbidities. So here the syndromic will be ACLD, and etiology will be alcohol, complication will be jaundice and ascites, and comorbidities nil. So this is how we have to tell. Okay. What is do you think? What is the criteria to make a diagnosis of alcohol hepatitis? You know, AAH, alcohol-associated hepatitis, the current terminology. Do you know any name of criteria to make a diagnosis? Anybody who takes alcohol is called alcoholic hepatitis, or is there any criteria to tell that this patient is having alcohol-associated hepatitis?
Either the male, the female should be consuming more than 40 gram of alcohol per day, as well as the male 50 to 60 gram per day, 50 to 60 gram of alcohol per day. For about 6 months with less than 60 days of abstinence, as well as the rise of AST to ALT ratio should be more than 1.5. The liver enzyme should be more than 50 to 200, ma'am.
Less than 400.
Less than 400.
Less than 400. What is the name of the criteria? You are absolutely right.
So less than 400.
What is the name of this criteria? You are right. What is the name of this criteria?
I just forgot the
NIAAA criteria. This is standard. So what happens practically is somebody who takes alcohol, if they have liver disease, it is just declared as alcohol-related liver disease. That is not so. So you should always work for other etiologies, even if the patient has significant alcohol history. That is the point that we should all know. So if your patient had tattooing, so do you think it need not be alcohol, it can be a combination of alcohol plus
alcohol and chronic viral hepatitis.
So, suppose today you have tattooing and you acquire hepatitis B. How long will it take for cirrhosis to develop?
General, common. Suppose acquiring the timeline for cirrhosis from acquiring the infection.
Today tattooing happens and hepatitis B virus has entered the body. How long will it take for developing acute hepatitis B, if at all, if it is of high viral load developing acute hepatitis B? How long will it take to present itself as cirrhosis or decompensated cirrhosis? Do you know the timeline?
Exactly, I don't know, ma'am. Probably the acute hepatitis B can occur within 1 month if the patient has got high viral load, ma'am. or more than a year if the
What is-
patient has
6 weeks to 6 months, 6 months, above 6 months. 6 weeks to 4 weeks to 6 weeks, 6 weeks to 8 weeks, 8 weeks to 8 months, like that acute, subacute, chronic. That's how they
So
describe.
incubation period is up to 6 months. Up to 6 months.
Up to
30
6
days to 6 months. So if tattooing has given you hepatitis B, either it can present as acute hepatitis B, which can happen somewhere between 30 days to 6 months. For it to present itself as cirrhosis, it takes how many years?
2 decades, no? Generally, madam, 2 decades.
Yes, sir. More than 15 years. More than 15 years. So 15 to 20 years, 20 to 30% of the patient with chronic hepatitis B, they are going to develop cirrhosis. This generally takes long time. So if the patient is an alcohol use disorder patient, then this combination will make the progress faster. So an alcohol plus hepatitis B fellow can develop a hepatitis B related cirrhosis at an earlier stage because there is one more insult. Same is for MASLD also. If your patient is obese, having metabolic syndrome and hepatitis B or hepatitis C, then the combination makes the progress faster. So generally it is 15 to 20 years from the time of acquiring the virus. So that's why whenever you ask for past history, sir was asking, why did you ask this history? That means you should know the natural history, right? Yesterday's tattooing is not going to develop chronic liver disease today. Suppose if the tattooing that you have shown was taken 6 months back and you expect the incubation period to be 6 months. So then this jaundice can be acute hepatitis
acute,
B.
the presentation of acute viral hepatitis, ma'am.
Do you think in acute hepatitis B, patient will develop ascites?
No, ma'am.
No. That means this acute and chronic liver disease, acute can be hepatitis B and chronic can be underlying alcohol-related chronic liver disease. That is how you have to give differential diagnosis for etiology. So you have a syndromic diagnosis of ACLF and you have an etiological diagnosis where as per the history of when the tattooing happened, then you can tell that this acute can be hepatitis B also. Acute can be alcohol-associated hepatitis, acute can be hepatitis B, whereas the chronic is alcohol-related chronic. That is how you have to give differential diagnosis for your etiology. So whenever you ask past history, ask when was the tattooing taken. Then only you can put it into the history. Otherwise, it's making no sense. Yes, history of tattooing plus. Not like that. So you have to tell when the tattooing was taken. So that gives significance. That makes you a better student who interprets the past history, not just tell the past history.
Absolutely, absolutely. Suppose, Balaji, this is a patient is not an alcoholic. For
Okay,
example,
sir.
if it's not an alcoholic, he has come with a jaundice. He has
Yes,
come
sir.
with ascites. What could be the likely other than alcohol?
Initial thing I'll be ruling out the viral hepatitis, sir.
No, for viral, madam, not discuss. It's not a virus.
Or else if the patient has got a systemic hypertension, type 2 diabetes, having a metabolic syndrome, I can suspect NASH, along with NASH progressing to
Metabolic associated.
MASLD, sir.
Yes.
Metabolic associated dysfunction steatotic liver disease, sir.
Absolutely, very good. So
how common is jaundice in MASLD? Do you think jaundice is seen in MASLD?
No, ma'am.
No. Then why are you telling MASLD in your patient? Your patient's presentation is jaundice. That means jaundice should have some etiology. MASLD doesn't present with jaundice because there is no acute inflammation in MASLD. It is a chronic progressive disorder where there is a steatosis, chronic hepatitis, and cirrhosis. So suppose if the patient is having MASLD, let the patient be a known case of MASLD diagnosed some 2 years back. And today, if the patient comes to you with recent onset jaundice and recent onset ascites, what will you think? What will you think as the etiology for the current presentation? Let the background etiology be MASLD.
Yes, ma'am. The patient may have an acute viral hepatitis or any kind of a toxin that has got an acute liver insult, ma'am. It can be either a drug.
What is the worrisome possibility? Something else? Underlying MASLD-related CLD known case, 2 years. Okay, fine. Now coming with jaundice and ascites of 25 days duration as you have cited. What is the worrisome problem that could have happened to the patient?
The MASLD can turn into an hepatocellular carcinoma.
Yeah, very good. Yeah. HCC. So any patient with chronic liver disease, if there is an acute worsening, always think of HCC also.
Malignant
acute worsening can be due to acute viral hepatitis A also because there is currently there is almost endemicity of hepatitis A in our area. So if the patient develops hepatitis A in the background of MASLD cirrhosis, then the patient can come with jaundice and ascites. It's accepted. But as such, for MASLD, you are worried when the patient is having acute decompensation. You should always think of HCC.
Malignant transformation.
You should also think of portal vein thrombosis. Bland portal vein thrombosis also can lead to sudden worsening of portal hypertension where there can be a ascites plus minus jaundice. So whenever a CLD patient comes with acute decompensation, always think of HCC. Always think of HCC.
Okay, Balaji. Suppose if the patient is having hepatocellular carcinoma, What
sir.
are the chances of hepatocellular carcinoma in a patient with hepatitis B infection? What are the how many? What is the percentage? What are the chances?
The chronic viral hepatitis.
No, see, viral hepatitis B,
Yes, sir.
90% to 95% is self-limited. That's why
Self-limited.
just like that, you cannot need not treat it because it is self-limited disease. Only 5 to 10% go for chronicity. Among
sir.
5 to 10%, only 1/3 may go for the hepatitis and the chronic liver disease. Among that, only 10 to 20% only go for cirrhosis. Among that, only 5 to 10% go for hepatocellular carcinoma. So it's still hepatocellular carcinoma is common. I mean, it is possible, but the chances are remote.
Very low.
By the time they develop, they go for a complication of the cirrhosis and may die of variceal bleed or spontaneous bacterial or complication happens in body. But the chances are, it goes like this. Only the 1/3, 1/3, 1/3, 1/3 goes there. Finally, 5 to 10% of the patients with jaundice, hepatitis B only go for this hepatocellular carcinoma. Right? As Madam said, so any person acutely develop the that is distension of abdomen, acute worsening of jaundice, think of either could be the hepatocellular carcinoma or portal vein thrombosis or spontaneous bacterial. But spontaneous bacterial generally don't develop jaundice, but they'll come with the complication of fever,
abdominal pain,
and this like that. Fine. Okay. Any drug can worsen like this? Any drugs?
Yes, sir.
What is a commonly used drug?
Sir, paracetamol.
Paracetamol, yes. Paracetamol poisoning, but paracetamol pharmacological dose is one.
The drug reaction which has got idiosyncratic reactions like isonic acid, which can immediately worsen, sir.
ADT, there is ADT, right? The
yes, sir.
Can have INH or rifampicin or pyrazinamide, which is more toxic.
INH, sir.
INH.
Pyrazinamide is the most toxic.
Pyrazinamide
is the most toxic. Next is INH. Next is
problem. Stop pyrazinamide. Don't give pyrazinamide thing. But yes, you said that the INH can have, but the skin manifestations, rashes are more. If you combine INH with rifampicin, more. If you combine INH and rifampicin, pyrazinamide, still more. So the worst drug in ATT is pyrazinamide. You have to stop it. And something idiosyncratic, as you said, idiosyncratic reaction is very common with the rifampicin, not with the INH. Rifampicin is the Redman syndrome. And the most of the time, intolerance due to rifampicin. You stop the drug, the intolerance of vomiting, abdominal pain, distension, everything will come down. So that is the one thing you keep in mind. Even though it's an alcoholic, you should ask for the drug history, then poison, toxin history, of course, the native drugs, all this you should ask to say whether you missed anything. Okay, what are the neurotransmitter which is causing encephalopathy? You talked about encephalopathy, no?
Yes,
what are the neurotransmitters responsible for encephalopathy?
Sir, there will be increased in the GABA as well as there will be increased in the blood ammonia, sir.
Ammonia,
then blood and then mercaptans.
Yes, ammonia, mercaptan, GABA. Then
there will be decrease in the neurotransmitters like glycine.
No,
there will be imbalance in the neurotransmitter production as well as receptor dysregulation in hepatic encephalopathy, sir.
Yeah. How this ammonia is how does ammonia cause encephalopathy?
Yes, sir. The ammonia is going to alter the blood-brain barrier permeability, going to lead to the astrocyte swelling as well as brain edema, leading to hepatic encephalopathy, sir.
Ammonia is a small molecule. It enters faster than the
glutamate.
Yeah. Glutamate is counted to glutamate or glutamine? Inside the cell. Glutamate is a stimulatory, excitatory transmitter, glutamate. But glutamine, when glutamate is converted to glutamine inside the astrocyte, it suppresses the opposite action, suppressing this thing, like the astrocyte function. So that's why they go for drowsiness, like encephalopathy feature. Okay, right.
Yes,
and that the octapamine, another neurotransmitter which is responsible for the encephalopathy part. Among all these things, this ammonia is the most like commonly encountered neurotransmitter for encephalopathy. Okay, fine. Right. Next
When do
one.
you call a chronic liver disease compensated? When do you call a chronic liver disease decompensated?
Whenever the chronic liver disease, the history has to be more than 6 months, ma'am. And then
Well, my question is, when do you call it as compensated versus decompensated?
The presence of decompensated features like jaundice, ascites, variceal bleeding, and hepatic encephalopathy termed as decompensated cirrhosis, ma'am.
So recently, in the recent guideline, jaundice is taken out. Actually, ascites, variceal bleed, encephalopathy are the decompensations. Why jaundice is taken out is there can be an acute insult which caused jaundice. Not as such the decompensation causing jaundice. Decompensation also will cause jaundice, but in the definition it is taken out because if there is an acute insult, it is reversible. It is reversible. Jaundice happening in a DCLD, decompensated chronic liver disease, where there is no residual properly functioning hepatocyte leading to liver synthetic dysfunction and jaundice. That is irreversible. Whereas acute insult, like for example, you told some alternative medicine intake. So if the medicine has caused drug-induced liver injury or a recent alcohol that has caused alcoholism, that can be reversible. So that is why jaundice is taken out from the definition of decompensation. Ascites, variceal bleed, encephalopathy. These three, if any one is there, it is called decompensated. Decompensated chronic liver disease.
Okay. Proceed, doctor. Proceed.
General physical examination. On examination, a patient awake, obeying oral commands, oriented to place, person, not oriented to time, no pallor, icterus present, no cyanosis, no clubbing, no bilateral pitting field edema, no generalized lymphadenopathy. Patient is afebrile. The
Patient
signs of
awake, right?
Sir?
Patient is awake.
Yes, sir.
Mild disorientation alone is there.
Awake. Why? What makes you to say awake? Why not a conscious oriented? Is there anything to make you to write awake?
Sir, patient is responding to our comments only, sir. Otherwise, he look drowsy. Whenever we ask question, patient is able to answer.
That's what, man. You have to put as a drowsy.
Okay,
because
sir.
What is the drowsiness? What is the drowsy state? Drowsy is nothing easily arousable.
Arousable. Okay, sir.
You will be sleeping or closing like that. When you call, immediately respond. Easily arousable, you will respond to the thing. As soon as until you converse, you will responding. Then you stop it again, go back. So that is a typical drowsiness. So if you want to say it is not drowsy, then put awake. If it is drowsy, you put drowsy. You might be answering just because you're answering. He is answering. You cannot put not. You cannot just leave drowsy. So whether because you already said that you are having encephalopathy features like that, so you have to include whether conscious oriented. This is typical terminology use. If it are drowsy, what is conscious?
The patient is alert and responding to the oral comments. The patient is alert all the time, sir.
No, not like that. You sleeping out, you alert all the time. Awareness of self and surrounding. Not only that, that's a partial. Able to recognize the internal changes in the body and act according to it. That's conscious. Suppose கொசு கடினா அவனுக்கு தெரியணும் அதுக்கு போட்டு கசு அடிக்கணும். That means he is able to understand something is biting, so he is eating. So that is called awareness. So that is definition. So awake definition means something vague terminology. Here it is not very appropriate unless the patient is having encephalopathy. Oriented to place in person, okay, fine. Not pallor, not icterus present, right?
Yes, sir.
Okay.
There is no cyanosis, no clubbing, no bilateral pitting field edema, no generalized lymphadenopathy, and patient is afebrile, sir.
Okay.
Signs of liver cell failure.
Clubbing.
Yes, sir.
What is the likely?
Sir?
You have instantly found clubbing is there.
Yes, sir.
What it suggests you?
It's suggestive of the patient is developing hepatopulmonary syndrome, sir.
Hepatopulmonary syndrome is emergency jaundice clubbing. There are two conditions in clubbing. You get clubbing. One,
primary biliary
cirrhosis. Two, alcohol also. Because chronic alcoholic, they develop clubbing. So clubbing, you get chronic alcoholic liver disease and also in primary biliary
cirrhosis.
Yeah. You have to think of the possibilities. Yes. Oh, fine. Go ahead.
Signs of liver cell failure: jaundice present, medarosis present, loss of pectoral hair and loss of axillary hair, abdominal distension is present, and loss of pubic hair.
This one, gentlemen, no, not like this. When you say signs of liver failure, you should be very specific signs of acute liver cell failure and signs of chronic liver cell failure. What are the signs of acute liver cell failure?
Jaundice,
Jaundice.
coagulopathy in the form of
Yes,
bleeding,
yes, agree. Coagulopathy.
and encephalopathy, sir.
Encephalopathy, there are so many conditions. Then one most important, jaundice, coagulopathy, palmar erythema, spider nevi, and fetal hepaticus. These are the signs of liver cell failure. And other things, all the features, it may come subacute and chronic. So it won't come as a liver cell failure. Okay. So now you start from the head to top to bottom, or meteorosis, jaundice, loss of pubic hair, anything else?
These are all the positive liver cell, the signs, positive liver cell failure signs I have seen in the patient, sir.
So what is not there? What is not there? What is expected? What is not there?
Sir, alopecia is not there. Bite out spot or subconjunctival hemorrhage is not seen. Bilateral parotid enlargement, palmar erythema,
What
dupuytren
about the
contract.
testicular atrophy? Is there?
Testicular atrophy is not there, sir.
Oh, what is expected or not?
It is expected, sir.
How? Why
Because,
testicular atrophy?
sir, because of the peripheral conversion of estrogen, which in turn going to cause the testicular atrophy, sir.
Peripheral conversion, aromatase.
Yes, sir.
Alcohol is an enzyme inducer. Yes, so aromatase activities increase to increase the metabolism of testosterone to estrogen, one gynecomastia, and also the direct effect on the Leydig cells. Direct
Yes,
effect on testicular Leydig cells, and it can suppress and it makes a disuse and atrophy. So when you say testicular atrophy, clinically,
clinically, I will measure the testicular volume with the help of archidometer, sir. Age-specific testicular volume.
Archidometer all the time with you. You are a clinician, man. You can go anywhere, anytime, just examine, tell it's a testicular atrophy.
Any sensation?
This testicular length or the size is lesser than the terminal phalanx of your thumb. It is a testicular atrophy.
Okay, sir.
Lesser than, right?
Loss of testicular sensation.
Loss of sensation, but I'm atrophy. I'm just like atrophy size. Size of the testicular volume, probably testicular volume, should be lesser than the terminal phalanx of the thumb. We call it this testicular atrophy because it should be minimum. The terminal phalanx of thumb should be the normal testis. If less than that, you can call. Of course, as Madam said, you can include atrophy, that loss of sensation. Right.
So your patient has only abdominal distension and no pedal edema. Are you worried about that? Are you concerned about that? You told no bilateral pedal edema. But abdominal distension is there.
Or is treated by diuretics by others, or it is not developed?
Not developed yet, sir. It is this is the first presentation the patient came to the hospital, sir.
Agree. Suppose if it's not developed pedal edema,
yes,
can
sir.
this be a hepatic venous thrombosis?
Yes, sir. It could be an hepatic venous thrombosis.
Yes. So because only the abdominal distension is there, and the ascent is there, jaundice is there. So typically falls in with Budd-Chiari syndrome and acute onset. You say 20 days of problem, right? 20 days or 2 weeks. So that's a problem. So probably they fit into it. Suppose if he has the pedal edema, abdominal distension, and jaundice, where is obstruction?
Sinusoidal obstruction is there, sir.
No. Sinus obstruction only has a liver problem. You have abdominal distension, pure hypertension, ascites will be there. Now you have pedal edema, abdominal distension, jaundice.
Pre-hepatic, I will localize the lesion to the pre-hepatic.
Pre-hepatic means poor man. How poor man get pedal edema? Unless you have chronic.
IVs.
Yes, it's IVC obstruction.
IVC obstruction.
Yes, it is an IVC obstruction or below the perineum, this in the heart, below the heart. You can have IV be anywhere between the hepatic vein to the IVC. If at all you have obstruction below pedal edema, abdominal distension, and the jaundice, right? Okay.
Yes, sir.
Suppose in this scenario, if there could be a cirrhosis, liver, portal hypertension, and pedal edema. It could be a IVC obstruction. Is there any clinical signs to say it is a IVC obstruction?
In IVC obstruction, there will be the dilatation of veins can be seen over the bilateral lower limb along with the pedal edemas.
Bilateral lower limb. Lower limb will get vein, huh? Just because
Balaji.
obstruction will get
IVs.
dilatation is a varicose vein like that. You won't get like that. Valves are there. It will block it. One clinical sign. You tell me one clinical sign.
Hepatojugular reflex.
No, you palpate the left testis. You can
Yes,
see
sir.
the
The varicose seal, sir.
yes. You can see the varicose seal.
Seal. Yes,
If
sir.
you're able to palpate the varicose in the left testis with the pale edema, acute onset of abdominal distension, jaundice, probably you can say IVC obstruction.
Okay, sir.
Suppose if it's not there, right? If it's not there, any test you or laboratory test you say it is an IVC obstruction. Any particular test you say it IVC obstruction. Laboratory simple test. Right, you can do urine protein. If urine protein is elevated, proteinuria is there is a pressure diuresis and pressure pushing. So abdominal distension acute onset, this the pale edema is there, varicose is still not there, but you look for urine protein. If urine protein is elevated, you suspect it is IV subsection. Okay. Clinically, can you is there any clinical evidence for IV subsection?
In IV subsection, we can able to see the dilated tortuous vein below the level of umbilicus, sir.
Below the level of umbilicus. Yes, yes. So it is below the umbilicus is tortuous vein. What is the direction of flow?
Below upwards, sir.
Below upwards. Right? Okay,
yes, sir.
Below upwards. What is the normal flow?
Normal flow, the normal flow is towards the umbilicus, sir.
Below upwards or towards umbilicus, eh? What is the normal flow of portal vein or around the portal venous flow? What will happen to portal hypertension?
If the patient has got portal hypertension, the direction of flow will be away from the umbilicus, sir.
Away from the umbilicus, portal hypertension. What is the
Yes,
normal
sir.
flow taken?
Towards the umbilicus.
Towards umbilicus. No. Normal flow also away from the umbilicus. It is
Okay,
exaggerated flow. It is exaggerated flow. Exaggerated flow in portal hypertension. The flows are also normal flow also away from the umbilicus only, but usually predominant over the lateral aspect, but away from the umbilicus. But it is this is a caput medicine. It is radiating from the umbilicus. All are away from only. It is radiating from the umbilicus. Caput medicus is very typical of portal hypertension. It is away from the umbilicus. The lateral aspect is very common. There is a classical of a normal flow. That is very common, right? So,
okay, sir.
what is corollary Baumgarten murmur?
Which is a continuous murmur which can be heard around the umbilicus, sir. Because
around
of the
umbilicus. Is it around the umbilicus? Around the umbilicus, below the umbilicus also around the umbilicus, lateral to the umbilicus also around the umbilicus. Is it around the umbilicus? It is the midway between the xiphisternum and the umbilicus. It is not around the umbilicus. That is a telltale evidence of
intrahepatic portal hypertension, sir.
Yes. So
because of the patency of the para-umbilical vein, there will be the because of the portal hypertension, the blood will flow to the para-umbilical vein, make it to patent, leading to the murmur, sir.
Left umbilical vein patent because of the this increased pressure. Okay, that you
Yes,
have
sir.
to, right. Proceed.
No. Tell me, what are the causes that can cause ascites? I will ask more practical questions. What are the causes where you will see ascites without pedal edema? This patient has ascites without pedal edema. What are the conditions? So first tell us theoretically what are the causes that can cause ascites without pedal edema. Then come to this patient and tell what are the causes for ascites without pedal edema.
Commonly, Buchiari syndrome, constrictive pericarditis, IVC obstruction can lead.
What are the common causes where ascites without pedal edema can happen? What are the common causes? Buchiari is a rare disease. What are the common causes where you will see ascites without pedal edema? Tell the commonest, Malignant ascites.
Malignant ascites.
Malignant ascites. See a stomach with ascites, see a ovary with ascites, see a colon with ascites, see a pancreas with ascites. Very, very common. So ascites without pedal edema, you think of something in the peritoneum. So you see for peritoneal
Peritoneal
inflammation.
carcinoma.
Peritoneal, primary peritoneal carcinomatosis, secondary peritoneal carcinoma.
Pancreatic
Second, one is malignancy. Second,
Pancreatic ascites.
pancreatic ascites. If there is, usually it is preceded by a acute or chronic pancreatitis. Doesn't come presently with ascites. Usually it is a painful ascites. Okay, then ascites without pedal edema.
Infection.
Tuberculous ascites. Common things, no?
Tuberculosis.
Tuberculous ascites. So you bring the uncommon Budd-Chiari first without telling common things like malignant ascites and TB ascites, where there will be no pedal edema. There need not be pedal edema if there is a peritoneal inflammation. So generally it is MTP. Malignancy, tuberculosis, pancreatitis.
MTP.
These three will cause ascites without pedal edema. Without pedal edema. Rare causes only constitutive pericarditis, but shares are all rare, whereas these are all very common. Malignancy and tuberculosis you see left and right. Day in and day out you see malignant ascites. CA breast with malignant ascites, CA ovary with malignant ascites, we see very, very frequently. Whereas Budd-Chiari is a rare diagnosis. Even for a gastroenterologist, Budd-Chiari is a rare diagnosis. So then Budd-Chiari okay, constitutive pericarditis okay. Tell me some causes in this patient where explanation in this patient for lack of pedal edema. You are telling alcohol-related decompensated chronic liver disease, portal hypertension, everything you are telling. Tell me why this patient doesn't have pedal edema. What is the physiological explanation?
Maybe the early phase.
Are you
of
concerned? My question was, are you concerned that this patient has only ascites without pedal edema? Are you worried? Or is it not fitting?
Yes, ma'am. The patient may have a portal vein thromb. The patient may have portal vein thrombosis or IVC thrombosis along with the presenting condition of some.
Okay.
That's possible. Yes. Splenic thrombosis, spot vein thrombosis. Because
what is the other concern? What is the other concern in a chronic alcoholic who has come with ascites without pedal edema and jaundice is there? What is the other concern?
Transformation.
Tuberculosis. Because the cirrhosis patients, mixed ascites. That's called mixed ascites. So you have cirrhosis as well as tuberculosis together will cause mixed ascites. Cirrhosis patients are 15 times at higher risk of developing tuberculosis than general population as per data. And this 15 times higher risk is more for extra pulmonary tuberculosis than pulmonary tuberculosis, and particularly for tuberculous ascites. So this patient, if he is an alcoholic, he has come with only ascites without pedal edema. My concern is what is the fluid analysis? Can it be mixed ascites? As you said, it can be hepatocellular carcinoma, which can cause hepatic vein thrombosis. It can be plain band portal vein thrombosis, which caused an acute worsening of portal hypertension where ascites came before pedal edema. Do you think a chronic liver disease patient can develop ascites just with the portal hypertension, or additional things are needed? For example, varices are there and varicose bleeding is there, you do banding. Such patient with chronic liver disease, which tilts the balance for the patient to develop ascites? Which exactly what event will tilt the balance for the patient to develop ascites? Ascites is bad or varicose bleed is bad?
Ascites is bad, ma'am.
Why?
Ascites is bad.
Why?
Varicose bleed is not bad.
Why ascites is worse than varicose bleed in a patient? Why it is a late manifestation of cirrhosis when compared to varicose bleed? Varicose bleed is purely due to portal hypertension. For ascites to develop, there should be two components. One is portal hypertension, one is low albumin. Without low albumin, patient will not develop ascites. So that means there is synthetic dysfunction for the ascites to develop. So in the staging of cirrhosis, stage 1 and 2 are compensated. Stage 1 is no varicose cirrhosis. Stage 2 is varicose cirrhosis.
Without bleeding, with absent ascites, ma'am.
With the bleeding happens next. Cackle D, there is something called cackle D where there is no varices also. That is the early stage. No varices also. No varices, varicose bleed, ascites, then multiple decompensations. Well, whether it is hepatic encephalopathy plus HRS, SBP plus HRS, all those things are late stage. So ascites is worse than bleed because bleed is purely due to portal hypertension. Ascites always indicate additional synthetic dysfunction in the form of low albumin. That is why all these patients will develop pedal edema simultaneously or even before ascites. Because low albumin will always lead to dependent edema. Low albumin always will lead to dependent edema. So if a patient with cirrhosis develops ascites without pedal edema, that means there is more portal hypertension than low albumin. Got the point?
Yes,
there is an acute worsening of portal hypertension. That means this acute alcoholic hepatitis can cause acute worsening of portal hypertension. That's why this patient is having ascites without pedal edema. Likely that he has mild pedal edema, which we have to properly examine. Most likely they will have, because low albumin usually exists, but it can happen where ascites can happen due to acute worsening of portal hypertension, which is known to happen with acute alcoholic hepatitis, or additionally due to portal vein thrombosis, or additionally, actually we are dealing with Budd-Chiari where ascites can be there without pedal edema. And one more thing is mixed ascites. So in this patient, I will think of mixed ascites or acute worsening due to AAH, acute alcoholic hepatitis.
Rather, we put it right. What is the mechanism of ascites in alcohol liver disease? You tell me the mechanism so that you'll understand what Madam clearly told. You'll understand the mechanism. If you say the mechanism, you'll understand the importance of ascites. What is the mechanism of ascites?
Sir, because of the translocation of the gut bacteria into the blood, there will be the release of the endotoxin, which is going to produces the pro-inflammatory cytokine. As a result, there will be increase in...
Gentlemen, you are talking about the spontaneous bacterial. I'm asking about this mechanism of ascites. It is not the translocation of bacteria from the gut going to the liver causing cirrhosis. I'm asking the cirrhosis mechanism by the alcohol.
Why portal hypertension is happening is asking.
You are asking so many cases. You are seeing ascites. You should know how the alcohol produces ascites. You should know the mechanism. No, you are a MD post.
Balaji, there are many theories of ascites formation.
Yes,
what is
underfill?
Okay, in nutshell, I tell you small things. It is very clearly in the Harrison. You can go and read it. When there is toxic injury to the liver, it causes sinusoidal injury initially. The endothelium get damaged. The endothelium will produce a nitric oxide. Because it is damaged, it not produce nitric oxide. So intrahepatic constriction, vasoconstriction due to decrease in nitric oxide, and it stimulates the stellate cells causing fibrosis. So stimulating stellate cells causing fibrosis, hepatic sinusoidal fibrosis, and damaging endothelium causing decrease in nitric oxide. This is happening in the liver. What happens in the peritoneum, the mesentery? Because the flow is not good, if the reverse flow takes place, the shear force against this gradient is causes the release of nitric oxide in the mesenteric vessels, in the portal vein, distal to that, because it is not able to go against the pressure or the obstruction. So the shear force causing release of nitric oxide. So the nitric oxide is excess in the mesentery or in the peritoneum, and the nitric oxide is less in the liver, so causing vasoconstriction. Not only this, there is release of these vasoactive growth hormones, and there is a transforming growth factor, and also this TNF alpha. So increased TNF alpha, vascular endothelial growth factor, nitric oxide, excess in this peritoneal circulation, that is causing vasodilatation, that is causing leaking of fluid, that is causing the slowly leaking into the peritoneal cavity. What happens as a result of this? There is a decreased flow, cardiac output, because everything, all the blood, per minute, 1.45 liters. That is 1.45 liters of blood from the liver comes to liver. If it is not going back, say 1.1 liter from the portal circulation, 350 ml from the hepatic circulation. So 1.45 liters per minute is going to the liver. When it is not going back to the heart, it finds a hypotension. So then renin-angiotensin release because of the hypotension, and renin-angiotensin water retention and increased ADH, water reabsorption, and all these things are causing, so increased the absorption, resulting in, but localized collection here. It is from the blood, fluid is not going to the heart, whereas whatever the fluid comes here, it get locked in the peritoneal cavity, so the ascites progresses. So that is the mechanism of ascites, and that is the reason why you develop only ascites in the early stage. Only later stage, where the albumin synthesis also got blocked, then you develop pedal edema. That is what the madam was referring to. So initially you will have ascites. For when the synthetic is also lost by the cirrhosis, you will develop the hypoalbuminemia that causing pedal edema. So by the time you develop pedal edema, then there will be a hypovolemia, even though the volume is high outside, but inside the volume is low. That's why the primary drug what you give is aldactone, because high secondary hyperaldosteronism is the main. It is not the Lasix, it is not the hypervolemia, it is only secondary hyperaldosteronism. So that's what happening. So that is the reason you have to go by pathophysiology. Even for the mechanism of the drug's action, you should know. Only then you can optimize the drug for the situation.
Yes,
right. So as my madam said, so madam question was very pertinent question. So the patient is having tuberculosis and the portal hypertension. How to say it is only tuberculosis ascites? You take the protein, ascitic protein. If the ascitic protein is more than 2.5 grams, most of the time protein should be albumin. But if it is ascitic protein is more than 2.5 grams, it is that there is no sinusoidal injury, there is no increase in sinusoidal pressure, so it is not a portal hypertension, it is only tuberculosis. If the SAG ratio, serum acetic albumin ratio is more than 1.5, that indicates increased sinusoidal pressure and increased sinusoidal injury. So if you say SAG ratio is more than 1.5, that is a telltale evidence for portal hypertension. If acetic protein is more than 2.5, that is a telltale evidence for no injury of acetic. So you have to go by that, then you according to the presentation, but whatever it is, by taking history. Now the very simple question, what they for undergraduate question is that the patient may develop ascites cirrhosis, ascites due to cardiac failure, ascites due to tuberculosis. So how to clinically differentiate, or with just one simple history you tell this ascites due to this cirrhosis, ascites due to tuberculosis, ascites due to cardiac failure. Is there anything?
Yes, sir. If the ascites is due to cardiac failure, there will be initially the pedal edema followed by ascites, sir.
Edema precedes ascites, cardiac failure. Next.
If the ascites is if the ascites is due to the liver disease, there will be initially the ascites followed by a pedal edema, sir.
Fine. Third, tuberculosis.
There will be ascites with there is no pedal edema, sir.
No, you have to add. So there is the ascites, there is fever and tenderness will be there. Fever, ascites, tenderness. It is tuberculosis. No fever, tenderness, ascites, malignancy. No fever, tenderness, and this ascites, malignancy. Fever, tenderness, ascites, tuberculosis. No fever, abdominal distension, only tuberculosis, cirrhosis liver. Fever, no fever, no abdominal distension, only pill edema, cardiac failure. And fetal edema, the facial puffiness, probably the hepatitis syndrome or hepatic liver disease, kidney disease also as well. So this is a very simple clinical clues. It will tell you the diagnosis. Right. Madam, we proceed.
Okay, sir.
Proceed.
Vital signs: pulse rate 65 beats per minute, regular rhythm, normal volume, normal collector, felt in all peripheral pulses, no radial or radiofemoral delay. BP 160 millimeters of mercury measured in right arm sitting position. Respiratory rate 18 cycles per minute, abdominal thoracic. Temperature 37.5 degrees Celsius, weight 72, and JVP is not elevated. Systemic examination.
Or not? Even JVP is important or not?
Yes, sir. JVP is important, sir.
Why it's important?
In case of constrictive pericarditis, there won't be non-pulsatile JVP, sir.
No. We are concerned about the liver disease. Why you are taking to the constrictive pericarditis? If JVP is elevated, if there is no hepatojugular reflux, it is Buchier syndrome.
Buchier syndrome.
Yeah, in Buchier syndrome, there may be elevated JVP, but hepatojugular reflux may not be elevated. It may not be present. That's a very typical feature for a Buchier syndrome. That's why it's important. Of course, there are so many other conditions. You'll have sometimes, no, this is a cirrhosis liver is a volume-ordered set where the volume is extra volume is maybe high, intravascular volume may be low, extravascular volume may be high, interstitial fluid may be high. So there are so many permutation combination will be there. The point is this. Okay, proceed.
Inspection, systemic examination, abdomen inspection, shape is uniformly distended, flanks full, umbilicus position is inverted, all quadrants of abdomen moves equally with respiration, no visible peristalsis. Skin and surface over the abdomen, there is no scar, surgical marks, sinuses, dilated veins over the abdominal wall. On head raising, there is no divarication of recti. On standing, there is no dilated veins. Hernial orifice is free. External genitalia, loss of pubic hair seen. This was a clinical picture of the patient.
What is the 11th quadrant? You are not told about the 11th quadrant. 9th quadrant, 10th quadrant, you told.
Sir,
Gender-
left supraclavicular fossa is also free, sir. There is no fullness
Yes,
in
yes.
the left supraclavicular fossa, sir.
Why it is important? No. Sometimes
Yes, sir.
just because alcoholic patient will miss maybe a malignancy, GI malignancy, alcohol also can cause ascites. As madam said, so many causes that is this malignancies can have this supraclavicular left supraclavicular node, which node that's supposed to be the 11th quadrant. And you're not told about the posterior part of the abdomen, posterior wall of the abdomen. You were told only about the anterior part, lateral wall. What about the posterior wall of the abdomen?
Posterior wall also is normal, sir. There is no dilated veins over the posterior abdominal wall.
Posterior wall, man. You
Sir?
have to tell about the spines. You have to tell the spine, sinus, or the AV malformations, or the sometimes maybe a TB spine. TB spine may be there.
There is
or,
no gibbous.
yeah, that you have to tell. That is a posterior wall of the abdomen. You are telling only about the anterior and lateral, right?
Yes, sir.
Yes, proceed.
Palpation, superficial palpation, abdomen is soft, non-tender, then no warmth. Deep palpation, liver is not palpable. A firm, smooth, non-tender mass, palpable at about 6 centimeter below the left costal margin. Firm in consistency, it moves with the respiration. Non-palatable, upper border cannot be felt. Probably the spleen. Kidney is not palpable. No inguinal, para-aortic, and supraclavicular lymph nodes.
Okay, spleen is palpable, right?
Yes, sir.
The mild, moderate, or severe splenomegaly, or moderate or large massive splenomegaly. When you say mild splenomegaly, when you say moderate, when you say massive splenomegaly. Clinically, you are a clinician.
Yes, sir.
Well,
Mild splenomegaly, the spleen is palpable just below the left subcostal margin, sir. Moderate, the midway between the left subcostal margin and the umbilicus. If it is crosses the midline, it indicates a massive splenomegaly, sir.
it crosses umbilicus. Okay. So you put it like this: 3 to 4 centimeter palpable is a mild.
Yes, sir.
4 to 8 centimeter is the moderate. More than 8 centimeter, that means crossing the umbilicus is a massive splenomegaly, right?
Yes,
So
sir.
here spleen is felt. Why? What is the characteristic of splenic enlargement? Characteristic feature, clinical feature. When you say spleen, it can be a left hypochondriac mass also, no?
Yes, sir.
What is the characteristic feature of the spleen? You say spleen.
There will be insinuations over the upper border.
Mm.
It is get above the swelling is not palpable. Bimanual palpation.
Man, it
Sir?
is a notch should be there. Notch.
Notch.
Why develop notch? Why you feel for notch? What is
Sir,
it?
because it is underneath the ribs of 9th, 10th, 11th.
Notch is a characteristic feature. Why the
Splenic notch. Splenic notch for the syllabus.
splenic notch? How do you get splenic notch?
Sir,
You should know no mechanism. How you get a spleen? How you get a splenic notch? It is during embryology where the splenic lobules fuses. The last, if you know, fuse, partially fuse. Before that, child will be born. So the last lobe won't be fusing. That's why it is slightly apart. The other fuse, 1 to 10 lobes will fuse. 11th lobe will not fuse. That's the reason you get notch. Why it enlarges towards the right iliac fossa?
Sir, because of the presence of splenorenal ligaments, sir. It
Spleno
will
down, man.
because of the ligaments like splenorenal gastrosplenic ligament, it will prevent.
Splenic. A gastrosplenic ligament, yes, splenic ligament downward. Yes, that's the reason why it enlarges towards the right side.
So you mentioned no para-aortic node field. Can you feel the para-aortic node?
You said para-aortic node. Huh? Is it possible to palpate the para-aortic node?
No, sir. This large enough, we can able to.
No, you can't palpate.
Palpate.
Para-aortic is retroperitoneal. How can you palpate over all this abdomen and abdomen and visceral organs? Not possible. Not possible.
Okay. So before you commit, you think twice. Don't just let it tell the para-aortic node is not palpable. How you get a para-aortic node palpable? Okay. Proceed. What is important here? Suppose a person who is having pancreatitis developed ascites. How
Yes,
clinically you say this is a pancreatic ascites? Clinically,
the patient may have an epigastric tenderness.
a tenderness fine then.
the patient may have a signs of Cullen sign as well as a great.
That's what Cullen sign. There is a hematoma, right side, or this around the umbilicus.
Yes,
Or this
and great Turner sign.
How
great,
common it is? Cullens and Great Tunnels, how common it is?
not common, not very common.
No,
But
he has to tell how common it is.
Yeah.
How common it is. In which group of pancreatitis you will see Cullen sign and Great Tunnels? In which group of pancreatitis you will see?
bleeding, no bleeding is bleeding.
Hemorrhagic pancreatitis.
Acute necrotizing pancreatitis
Pancreatitis.
can have great tunnels and Cullen. That too only 3%. So if you have 100 patients with pancreatitis, 80% are interstitial pancreatitis, where you will not see Cullen signs later. Only 20% are necrotizing pancreatitis. In that, 3% can have Cullen signs great tunnels. This generally happens in acute pancreatitis. So today, patient has come with acute abdomen pain. Within next few days, you may see this Cullen's great tunnels because of necrosis. Whereas ascites is not seen in acute pancreatitis. Ascites is seen in chronic pancreatitis or a
pancreatitis.
sequelae of acute pancreatitis. So generally see ascites in a very late stage of acute pancreatitis. It's a sequelae. It doesn't happen during an acute episode. So you can't make out an ascites as pancreatic ascites by looking for Cullen's or great tunnels sign.
Anything you see around the umbilicus? Yes, madam. Anything you see
Sir,
around
there
the
is
umbilicus?
no caput medusae.
No, anything node. You can infer.
What Sister
node?
Mary Joseph, the Joseph nodule, sir.
See, what it indicates?
It indicates an underlying gastric malignancy.
Gastric gastric peritoneal malignancy.
Peritoneal mets.
Mets.
Gastric go to the left supraclavicular node. It's a peritoneal malignancy, right?
Yes,
But
sir.
that was described by Sister Joseph, so Mary, and this thing fine. So you have to look. No, it is not an actual condition, as Madam said. It is, as a postgraduate, you should know some why, because someone asks a question, you should be able to answer. Okay, right. Proceed.
Yes.
What is this red thing? There's something you see in red. Is erythematous? Oh no. Oh, no. Okay. Shadow.
Yes.
Right.
This video depicts the traditional method of liver palpation, ma'am.
Is a traditional method. What is a tradition? You are keeping over the right hypochondrium. Is a traditional method.
Sir, to start.
When to start? How to examine the liver?
Sir, the liver has to palpate it from the right iliac fossa towards parallel to the right subcostal margin, sir.
Yes, gentlemen, don't do like this. It is not, you are doing only dipping method. So there is a regular manual method is that you go from the right iliac fossa by inch, not by inch, centimeter by centimeter. You go slowly. You don't dip, because of course here is ascites there. But initially, ask the patient to take deep breath. You keep your hand parallel to the costal margin, lower, that is the right iliac fossa. Then slowly you move and ask the patient to take deep breath. Even though fluid is there, you just give gentle deep pressure. Then you can feel the liver and the sharp margin be feel. If it is not, suppose the liver is not felt in a classical method, manual examination, then what is the next method you opt for?
Dipping method can be done, sir.
Only then you go dipping method. Dipping method, again, not the thing, the fingertip. The fingertip dipping method, you should use the fingertips, not the lateral aspect of the finger. That is not the dipping, because only then you touch, you go like this, and wherever it is felt, then you have to measure. If that is also not felt, what do you do?
And then insinuation method.
Insinuation, liver insinuation or no?
Listen, we have to palpate right directly from the right subcostal margin.
No. When a massive ascites, you can't bear by the lower lobe, lower border. You just percuss, you determine the upper border. Right. Because when the fluid is there, you cannot down, still you cannot palpate. You just go to the percussion method, you find out the upper border, and then you try to palpate. Even dipping method, you are not able to say. You say, I am not able to localize the lower border because of the massive fluid. I am able to only localize up to the upper border of the liver. Right. Okay. How to palpate the spleen?
The traditional method, which includes a palpation from the right iliac fossa diagonally towards the left subcostal margin.
Fine. Okay. Then, if it is not felt?
If it is not felt, then bimanual palpation of the spleen can be done.
How to do palpation?
Sir?
How to do bimanual palpation of the spleen?
The left hand of the examiner should be placed placed back of the left subcostal margin, and we have to give firm pressure by the left hand. By the right hand, we have to insinuate underneath the left subcostal margin, sir.
For that, you have to put the patient on the right lateral position.
Right lateral position, sir.
Right lateral position, you have to palpate as the patient take deep breath, and you keep your palm on the lateral aspect of your left side of the thorax, abdomen. Then ask the patient to take deep breath. What is, if that is also not performed, what is the other method?
Then hooking method on placing the patient in the
examiner which side and the patient, which side of the patient examiner?
Left side of the patient, sir.
Yeah, exam should go to the left side, not on the right side. Normally,
Yes,
exam is on the right side, but when you for the hooking method of spleen, you have to go on the left side, and then you hook it and ask the patient to take deep breath. So, what is Nixon method? What is Castle method?
These are all the splenic percussion methods, sir.
Yeah.
Castle method, we have to percuss either a 8th or 9th intercostal space under the at the anterior axillary line level, and then we have to ask the patient to take a deep inspiration. If it becomes resonant, the spleen is large. The spleen is not enlarged.
Posture or prone posture or lateral posture for a Castle method. Right lateral portion.
That is
Nixon method, man. It is Castle method is a supine posture.
Supine portion.
Supine posture, you have to percuss on the anterior axillary line. At the 8th space, you have to percuss. You ask the patient to you just percuss the note, resonant, a dull note. You ask the patient to take deep breath. If dull note become resonant, it is a splenomegaly. Yeah, that is resonant to dull is a splenomegaly. Nixon method. Nixon method,
we have to ask the patient to the right lateral decubitus position.
And you percuss it where?
The midpoint of the left subcostal margin, perpendicular towards the left subcostal margin, sir. Till 8 centimeter, the dullness of spleen can be elicited. Above 8, beyond the 8 centimeter, if the dullness is persists, it indicates a splenomegaly, sir.
Yeah, if we go beyond 8 centimeter persists, why it beyond 8 centimeter persists?
Because a spleen gets enlarged towards the right iliac fossa, sir.
No. Spleen enlarged posteriorly first.
Superiorly and posteriorly initially, sir.
Initially, posteriorly, only then, because of it only, it enlarges beyond 8 centimeter from the perpendicular to the costal margin. So that's the reason why that is more sensitive test. This test is more sensitive test. So that is very reliable for early splenic enlargement. So you have to park it. Good.
Suppose if you ask your radiologist to do an ultrasound for this patient.
Yes, sir. Yes, ma'am.
What is the normal spleen size as per ultrasound?
As per ultrasound.
What is the normal spleen size?
Clinically
also, when are you worried? No, I'm asking ultrasound.
Ultrasound.
When will you think it is splenomegaly? As per ultrasound. You have a lot of clinical methods to make a splenomegaly, but often patient comes to you with a scan taken outside. Generally, often in the practical, you are sitting in a tertiary center, you will always have a patient who comes with ultrasound. So what is the size of the spleen for which you are worried in an ultrasound?
Exact measurement.
Well,
what is the normal size of spleen in ultrasound? That is a normal size, means from the whatever you are not able to palpate also they are going to measure, no?
Yes,
what is the normal size? Less than? Long axis measurement is less than 12 centimeters. So anything more than 12 centimeters, you consider it as splenomegaly. So generally, if it is 12, they'll give borderline. Less than 12 is normal. Anything more than 12 is splenomegaly. So even for a 13 centimeter spleen, you're worried. In a normal routine clinical palpation, you may not be able to make up a 13 centimeter spleen. Only when it is much enlarged, you're going to see. So in an ultrasound, the border limit is 12 centimeters. It is a long axis measurement. If it is a side-to-side measurement, it is 6 to 7 centimeters. But generally, in all ultrasound, as a rule, they will give a long axis length only. As a rule, they will give long axis length, which will be up to 12 centimeters. So even 13 centimeters is significant.
The simple anatomy, they say no, 3, 5, 7, 9, 11. Right? What is 3? 3 is the width. 5 is this thing, what the depth. 3 is the depth, 5 is the width, and 9 is the length. And 9th, 10th is the long axis
of the spleen.
Up to 11 centimeter.
11 centimeter.
So that's our 3, 5, 7, 9, 11. So that's what splenomegaly, right? Okay, right. So now what is it? Any other clinical, you have any auscultation method? Have you done any auscultation of these patients?
Yes, sir. There is no venous, there is no bruit over the right hypochondrium as well as the left hypochondrium. There is no continuous murmur
Okay.
midline between the xiphisternum and the umbilicus, sir.
But was there this thing dilated vein seen anteriorly?
Dilated veins is not seen, sir.
What are the named or veins in the ascites? In ascitic patient, there are some named veins.
Caput medusae.
That is not a named vein. It is not named by somebody else. You know, vein of Sappi, vein of Retzius.
Oh, sir.
Vein of Sappi is a retroperitoneal vein, which is typically enlarged in this IV subsection and Pachyara syndrome. These are two conditions. But when the patient comes with ascites, these are the two named veins the examiners will ask, right?
Yes, sir.
Right. So posteriorly, was there any finding posteriorly?
Posteriorly was normal, sir.
Normal. You
I'm
always
not able to elicit any dilated veins or gibbous or any spinal deformity.
fine. You should look for, right? Fine.
Yes, sir.
Right. So what is putting to other system involvement?
Other system involvement, percussion. I'm able to elicit the shifting dullness, sir. Drops.
Okay. This Perkins shifting dullness, right?
Yes, sir.
So for a minimum, how much of fluid is required for a shifting dullness?
Minimum 1 liter. We need to elicit a shifting dullness clinically, sir.
Clinically, 1 to 1.5 liters, not exact 1, but 1 to 1.5 liters. Okay. Puddle sign clinically.
Puddle sign clinically, there should be more than 120 ml, sir.
That is given in shift in the pathology, but usually clinically 300 ml. Clinically 300 ml. Ultrasound 120 ml, and puddle sign also 120 ml is given in shift. But I don't know whether clinically it's 120 ml can be detected. At least minimum 300 ml should be detected. Should be there to clinically say it's a puddle sign positive. So that is it. Fine. Okay. Right. So will there be a shifting dullness when the patient having 10 ascites?
No, sir.
Okay.
In 10 ascites, we may elicit only the fluid thrill, sir.
Okay. Okay. What are the complications of ascites?
Spontaneous bacterial peritonitis, secondary bacterial peritonitis.
Any complication of a portal hypertension? I'm asking complications of ascites.
Ascites, sir. Because of the tense ascites or a chronic ascites, it will increase the intra-abdominal pressure. As a result, there will be inguinal hernia. There will be divarication of recti.
Exactly. So the inguinal hernia is a complication of ascites.
Okay, sir. Okay, sir.
Maybe that's a complication because the tension causing the problem, not
sir.
The liver is causing problem. Okay, so this is a common. Okay, what are the complications of this patient? What are the complications you expect in this patient?
The complications like inguinal hernia, I may expect.
Let's forget about the ascites. In this patient, you say you can make a complete diagnosis, come to a complete diagnosis so that we can discuss.
What is hepatic hydrothorax? Hepatic hydrothorax.
Hepatic hydrothorax, because of the ascites, there will be percolation of ascitic fluid from the diaphragm to the pleural cavity, ma'am. As a result, there will be production of the. As a result, there will be hepatic hydrothorax formation, ma'am.
Why hydrothorax? Why don't you call it a hepatic pleural effusion? Why you call it hydrothorax? Because
it is a ascitic fluid that is percolating from the peritoneal cavity to the pleural cavity, sir.
What is pleural effusion? No, why you call it hydrothorax, man? Your fluid is in the peritoneal cavity is called pleural effusion. Ascite is in the ascite is. Why you call it hydrothorax?
So the problem is in the pleura, it is pleural effusion. The problem is ascites here. That is one of the complications of tense ascites is to develop hepatic hydrothorax. Suppose if you analyze the hepatic hydrothorax fluid, it will be as same as the ascitic fluid. That also
composition.
Will be low protein, high spag, and low cellularity, and it will be transient.
You should understand why simply they are keeping terminology. Just like they don't keep terminologies, they use very appropriately the terminologies. It is only a just fluid like water like. It is not a high rich protein rich fluid. If it is protein-rich fluid, they can call whatever the name for the fluid efficient, but it is a hydrothorax because it's almost like a watery and there's no protein. That is the reason this is called hydrothorax. So suppose a patient is having massive hydrothorax. What is it? Do you put intra ICD and drain the fluid? Massive hydrothorax.
Massive hydrothorax. If the patient is symptomatic, I may proceed with ICD, sir.
ICD. When you remove the ICD, gentlemen, forever in your life put ICD for those patients, because it will not get. You cannot take the.
It will never stop.
It never stop. It will give a complication, then see you. It is not an indication for hydrothorax, because once you put it, the fluid keep on coming. It never stop. Because the opening is there, still persisting. So always try to remove from the ascitic part, not for the thoracic part.
Thoracic.
If you remove the fluid, it will automatically come back to the ascites. I mean ascitic side, the peritoneal side. You don't ever put, because a lot of times some people put ascites, tube and sent to the hospital. They never improve and lead to complication and death. So that's the one thing. Okay. So what are the tests? What is the final diagnosis? What is case? Sphenomegaly was there now?
Yes, sir.
What is the diagnosis?
A case of chronic decompensated liver disease, ethanol related, with the complications of portal hypertension and grade 2 hepatic encephalopathy, without the clinical evidence of spontaneous bacterial peritonitis.
The chronic decompensated, same thing. You have got evidence of cirrhosis, you have got evidence for portal hypertension, you have got evidence for decomposition, that is decomposition in the form of acute liver failure, and then you have got evidence for the other complications. Why you again put in the decompensated liver disease? That's what that they won't agree with the decompensated. We don't put
cirrhosis of liver.
Yes, put it as cirrhosis liver, portal hypertension, acute on chronic liver disease.
Liver disease.
Ethanol
related.
Acute on chronic liver disease with the cirrhosis, portal hypertension, with the massive ascites, like probably me. And what are any complication here other than that ascites?
Yes, sir. Because of the ascites and splenomegaly, there is a portal hypertension, and the patient has got a grade 2 hepatic encephalopathy without the clinical evidence of the spontaneous bacterial peritonitis, sir.
When grade 2 encephalopathy is there astraxis?
Yes, sir.
Astraxis is there?
Astraxis is there, sir.
What is astraxis?
The flapping tremor on outstretched hand, sir.
Outstretched, how the flap?
It will be regular and.
It's a wing beating tremor. It won't flap like this. It is a tremor you get in alcoholics also.
Yes, sir.
That tremor is not a tremor of wing beating. Is a wing beating tremor is the outward movement, outstretched hand, persistent, outstretched hand at the wrist. So it go for a sudden fall and unable to maintain the sustained contraction. Contraction followed by relaxation. This outward movement. That's what we call the wing beating tremor or liver flap or the astraxis. It is not just a tremor. It's the wing beating tremor, outward movement that should be there. So use hepatic encephalopathy, right? Okay.
Yes, sir.
Was there any time variceal bleed in this patient?
No, sir.
So what are the chances of bleed or spontaneous bacterial peritonitis in this patient? What are the chances of spontaneous bacterial peritonitis in this patient?
Since the patient has got an ascites, there is an.
Possible to say you develop spontaneous bacterial peritonitis or not?
Sir?
Is it possible to say this patient will develop spontaneous bacterial
Yes, sir. Sure,
peritonitis?
sir.
How? Tell me one test will tell you this patient is prone for spontaneous bacterial peritonitis.
Sir, if the ascitic fluid protein is less than 1.5 gram per deciliter, he is more prone to develop spontaneous bacterial peritonitis, sir.
Very good, excellent. That is what expected. So if the ascitic albumin
Yes,
protein is less than 1.5, or sometimes they say 2 also, and they are very prone for this
spontaneous
bacterial peritonitis. Okay. Will he develop bleeding, varicose bleed? When he develop varicose bleed? What are the chances of developing varicose bleed in this patient? At what portal vein pressure he will bleed?
Sir, if the portal vein pressure is more than the hepatic venous pressure gradient is more than 12 millimeters of mercury, the patient has got a high chance of variceal bleeding, sir.
No. Something, see, hepatic venous pressure gradient is different, portal venous pressure is different. Right? If
Yes,
portal
sir.
venous pressure more than 12 millimeter mercury, the chance of bleeding is more, 30%.
Okay,
But
sir.
hepatic venous pressure gradient is more than 5, it is a portal hypertension.
Portal hypertension.
This is a gradient, that is only pressure.
Okay,
But
sir.
as per the latest definitions guideline, it's only the portal hepatic venous pressure gradient more than 5 centimeter on the millimeter mercury is called portal hypertension. But when you say portal varices per se, venous pressure per se, more than 12 millimeter mercury, the chance of bleed is 50 to 30%. Right?
Yes,
That's
sir.
right. Okay. Suppose especially I am only the fundus varices, nowhere else the varices. What is it?
It can be of gastric antral vascular ectasia, sir.
Fundal varix.
Fundal
Fundal.
varices.
Fundal varices.
Very good. Only fundal varices. What about splenic vein thrombosis?
Oh, splenic vein thrombosis.
Very good. Splenic vein thrombosis varices. Very typically we get in this fundal varices. Fundal varices is very common with the splenic vein thrombosis. So you have to suspect splenic vein thrombosis when you have only fundal varices. Okay. So can you get varices? Usually varices you get in the lower of 1/3 of the esophagus. Any condition where you get the upper 1/3 of the esophagus varices? Varices usually lower 1/3 of the esophagus. No.
Esophagus. Yes, sir.
Any condition where you get upper 1/3 of the esophagus? In SV substruction. In SV substruction, you will get varices in the upper, this not the lower, because the SV territory is the upper 1/3. So you get the varices over there. So that also you have to keep in mind, right?
Yes, sir.
Okay, right. So what are drugs you give for reducing the portal pressure?
Non-selective beta blockers can be given, sir.
Why non-selective beta blocker?
Because it has got both beta blocking agent as well as unopposed alpha action, which has got an vasoconstriction effect, sir.
What are the receptors in the vessels? And you say unopposed action, opposed action. What is that?
Sir, beta 2 receptor along with alpha 1 receptor, sir.
Alpha 1, beta 2 receptor where? In the mesenteric arteries, right? With vessels. Okay.
Yes, sir.
So if you block the beta receptor, alpha 1 activation is there. So vasoconstriction in the splanchnic vein, right?
Yes, sir.
Okay. More than the splanchnic arteries, the collaterals. The collaterals, the actions are more. So that the vasoconstriction by the alpha action, and because it's blocking the beta 2 receptors, or the alpha 1 receptor unopposed action, so decreases the portal circulation, that is splanchnic circulation, and decrease the collateral circulation, thereby portal flows decrease. So that's the primary drug. And now, what are the new drugs apart from your the interval? What do you now new drug will do for the portal venous pressure management?
Portal venous pressure.
Carvedilol.
Carvedilol can be given, sir.
Carvedilol is a potent action because both alpha and beta action is there. So it is very useful, and so that can be given. Any other drug you can give for the reducing the portal pressure?
Nitrate.
Octreotide, right? Octreotide, how does it act?
That is also somatostatin analog, which has also got an vasoconstricting properties in
the splanchnic vessels, so it decreases the pressure, right? But the problem is it inhibits all the hormones. That's one problem. That's one thing. Okay. What other drugs you give? Do you have any effect of domperidone? What is the effect of domperidone in the portal bleed? Domperidone constricts the gastroesophageal sphincter.
Okay, sir.
Okay, it is a prokinetic drug. This also constricts the esophageal sphincter, thereby the pressure flow in the short splenic vein, that is short gastric vein, is less. So
yes,
if you add dopamine, that is a blocker, that is domperidone, in a patient who is having portal hypertension, it decreases the short gastric venous pressure, thereby it transiently it improves. Now, you cannot be using regularly, but at least for transiently it can do that. Okay, right. Anything else?
What are the clinical signs of spontaneous battery peritonitis in a patient cirrhosis? What are the clinical presentation of spontaneous? What is the commonest presentation with which an SBP patient will come to you? When do you
The
suspect?
patient may present with a fever and acute onset abdominal pain, ma'am.
No.
Abdominal pain, fever, right?
Acute onset abdominal pain is rare in SBP.
Discharge.
What is the commonest presentation? What is the commonest presentation of SBP coming to you?
Fever.
Fever.
With loose stools.
Fever with loose stools.
Fever
Okay.
with loose stools. That is the most common presentation. Anybody with hepatic encephalopathy, you suspect SBP. Anybody with increasing creatinine, you suspect SBP. Anybody with fever, you suspect SBP. SBP is one of the life-threatening complications. So you should not hesitate to tap the fluid for counts in any worsen. Unlike perforation peritonitis, which is a secondary peritonitis, these patients need not come with abdominal pain and they will never come with peritoneal signs. They will never have peritoneal signs because there is no severe inflammation in the peritoneum. So you will not have guarding rigidity, you will not have severe tenderness. They will not, rarely only they will come with acute abdominal pain unless the counts are very high. Suppose a CLD patient comes with acute abdominal pain, you have to think of acute severe abdominal pain, like a surgical abdomen, which is not a feature of SBP, which is not a presenting symptom of SBP also. You should think of hemoperitoneum, intraperitoneal varices, mesenteric varices, omental varices can rupture or HCC can rupture. So suppose a known case of chronic liver disease comes to you with acute abdomen like a surgical abdomen with guarding, you will obviously think of routine surgical causes like perforation. But you will also, for a specific for CLD, you will think of hemoperitoneum due to intraperitoneal varicose rupture, which is a rare complication. What I mean to tell is SBP will come with subtle signs. They will not come with overt signs of peritonitis. They will come with subtle signs. So if you have a follow-up patient coming to you to the OPD and creatinine was 0.7 earlier, now creatinine is 1. So 0.3 rise as per definition is AK. Then you have to think of SBP. You have to think of SBP. You should immediately stop beta blocker. You should immediately stop diuretics. Look for SBP. So that's subtle signs. So we should always remember that SBP will come with subtle signs, but it is very much life-threatening. Unless we suspect in the window period, we are going to miss and the patient will come with organ failure. Patient will come easily with HRS, hepatic encephalopathy, shock. So you should think of SBP for any worsen, any clinical worsening, think of SBP.
Any simple test to say it is a simple primary peritonitis or secondary peritonitis, Balaji? You tell this is a secondary, it is a primary. That's all. Peritonitis.
Sir, by seeing the WBC cells of the ascitic fluid, if it is
man, you have to go to a laboratory. You're a clinician, no? Always think that you're a clinician. On history examination, seeing, observing, that's all. Make the diagnosis. You draw the fluid.
Yes,
It's bilious. It is a second bacterial. It is a secondary bacterial. It is a turbid. It is a primary. So it is spontaneous bacterial. So crowding, cloudy, turbid. It is a secondary spontaneous peritonitis. If it is a bilious, it is a secondary peritonitis. It is a biliary perforation. So that simple test it will guide you. That's one thing. Okay. Suppose if it is how to say it is a pancreatic peritonitis or not?
By seeing the ascitic fluid amylase and lipase, we can able to differentiate.
How much? More than 1,000.
More than 1,000.
You say ascitic fluid amylase more than 1,000. It is suggestive of the pancreatic ascites. When you say it's a chylous ascites,
the ascitic fluid, cholesterol as well as triglycerides will be more, sir.
How much?
More
than 200.
200.
Triglyceride more than 200. It is a chylous ascites. Okay.
Do you do for this patient once you treat the hepatic encephalopathy with anti-ammonia measures, look for SBP, treat alcohol hepatitis? Do you think you have to routinely do endoscopy for this patient to assess varices?
Yes, ma'am.
When do you order for an endoscopy in patients with chronic liver disease?
Chronic liver disease?
Generally,
if the patient has presented with the decompensated features without ascites itself, the baseline endoscopy has to be done, ma'am.
When all you Anyway, every alcoholic you order for endoscopy, or there are indications where you have to ask for
You
it.
want to do endoscopy for this man?
Yes, sir. Since he has got decompensative features like ascites
No,
as well.
you want to do endoscopy. Why you want to do endoscopy? You tell me why you want to do endoscopy. Just because you are having endoscopy, you want to do endoscopy?
No, sir.
This man, why you want to do endoscopy? Is he having, are you suspecting the varicose bleed here? No.
No.
Are you suspecting you want to do intervention here? What
No.
intervention you want to do by endoscopy now? He is having encephalopathy. We want to do endoscopy.
So what are the indications for endoscopy in a patient with chronic liver disease? This hepatic encephalopathy, during encephalopathy you don't do, obviously. What are the indications for getting endoscopy in a patient with chronic liver disease, or I mean cirrhosis, not necessarily chronic liver disease terminology. If you have a cirrhotic fellow, when do you ask endoscopy? What are the indications?
Ma'am, when there is a disappearance of dilated veins or spider hemangioma, clinically, I may suspect varices, and then I can order for
hypertension, right? Hypertension, tachycardia. That is initially
No,
big.
that is acute bleed. So there is something called CSPH, clinically significant portal hypertension. Okay, it's
Yes,
called,
sir.
that's a terminology. Have you heard of the terminology?
Yes, ma'am. When there is a
Clinically significant. If you think your patient has clinically significant portal hypertension, that means you should do endoscopy even if the patient doesn't have past history or current history of bleed. So what are the evidence of clinically significant portal hypertension? Generally, clinically significant portal hypertension means HEPG more than 10. Means that is
more
the
than 10
correlation.
mm mercury.
That is core. Anything more than 5 is portal hypertension. Anything more than 10 is CSPH. So anybody with CSPH, even if they do not have past history of or current history of bleed, you should ask for endoscopy to look for varices and plan for a primary prophylaxis. So what are the evidence of CHPH clinically? Do you think CSPH can be identified clinically, or any specific test is needed?
Age, clinically, I don't know, ma'am, but with the help of liver stiffness measurement,
Liver stiffness is
stiff,
sophisticated. We are much concerned about clinical. Clinically significant, you are absolutely right. In a sophisticated situation, you have to do a liver stiffness measurement. If it is more than 25, it is called CSPH.
25.
Liver, which is not possible in every center. How do you decide that the patient has got clinically significant portal hypertension? It's available simple modalities. Simple test. Platelet count. Platelet count.
Yes, ma'am. If it is less than 1,50,000.
Yes, less than 1.5 lakhs.
1.5.
Particularly if it is less than 1.1 lakh, or a splenomegaly seen in ultrasound, or the presence of perisplenic collaterals in ultrasound. Presence of ascites itself indicates clinically significant portal hypertension. So you have ascites, you have splenomegaly, you have collaterals in Doppler, or you have low platelet count. These
And
are
reversal
the
of portal venous flow.
These are the clinical features of portal hypertension. So then you ask, that means the patient has CSPH. That means you have to ask for endoscopy to look for varices, because patient needs primary prophylaxis. By giving primary prophylaxis, you can prevent bleed. A combination of beta blocker plus banding is superior to beta blocker alone. It has been shown, very well data proven. So combination of beta blocker plus banding is superior to beta blocker in preventing the first varicose bleed episode. So that means for every patient with CSPH, clinically for a clinician, you can make sure that the patient has CSPH based on splenomegaly, low platelet. So anybody with low platelet, cirrhosis, not every low platelet, cirrhosis with low platelet, you always think of presence of varices. In a bleed, obviously.
Yes, please.
So in a bleed, obviously, whenever the patient comes with any hypotension, postural giddiness, tachycardia, unexplained HB drop, you ask for scopy. That is a bleed, acute indication. But generally, a preventive prophylactic indication is whenever you suspect CSPH.
Okay. If the platelet is low, why is the platelet low, Balaji? Is in
sir, the thrombocytopenia may be due to hypersplenism or decreased hepatic thrombopoietin synthesis.
When you suspect hypersplenism? When you suspect hypersplenism?
The patient is having thrombocytopenia with
when you have thrombocytopenia and leukopenia, you suspect with this splenomegaly, you suspect hypersplenism. Okay, one thing. What is there any relation of platelet and spleen? Is so very important. 1/3 of the body platelet is stored in the spleen. 1/3 of the spotting platelet. Okay, so
Okay, sir.
if it is the spleen is having a circulatory disturbance, there's
Yes, sir.
so much of platelet deficiency will be there. That's why on top of your coagulopathy secondary to the liver, that is coagulation factors, the platelets also goes down. You have to look into the platelet. You have good platelet transfusion also if there is a low platelet, because this it complicates the hemorrhage in a patient with acute liver cell failure. Right? That's
Yes,
one
sir.
thing you should do. Okay. Then what is Mars?
Mars.
Mars, M-A-R-S.
Molecular absorbent.
சார் சொல்லி கொடுப்பாரு, அங்கே சொல்லி கொடுத்துரு, இங்கே சொல்லி molecular absorbent recirculation system. Molecular absorbent recirculation system. Why, when you will use it, what is the indication for this? It is a short gap arrangement for the before the transplant, liver transplant. So
Okay, sir.
when you have a severe disease, before you planning for liver transplant, you use Mars. It is a short gap arrangement. It's a bridging procedure, and like it like a dialysis machine used for a kidney failure. Use this Mars machine for the liver failure. It is reabsorbing the cytokines and all these toxins, and you are preventing the patient going for encephalopathy. So that you can do. So again, this TIPS is a procedure very commonly they do, but nowadays I think they are also not doing that one. That is more prone for encephalopathy.
Encephalopathy.
Hepatic encephalopathy very common with the TIPS. So you go for Mars and go liver transplant if it's an acute.
Do you think any procedure has taken a lot of recent fancy in liver ICUs, which is something equivalent to dialysis for liver failure patient? Any procedure that has taken up a lot of
Ma'am,
interest in recent
alpha
days?
pump insertion for
That is for
ascites, ma'am.
ascites. Anything,
Ascites.
something equivalent to dialysis, which has gained a lot of interest in recent days in liver ICUs. Something is gaining a lot of significance, more and more data coming up. Something we regularly do in liver ICU, which is equivalent to dialysis for liver failure patients.
It's a Mars
Plasma exchange. Plasma exchange.
Plasma exchange.
Plasma exchange, which is lot of data coming up. Acute liver failure, acute on chronic liver failure, drug-induced liver injury, alcoholic hepatitis, rat killer paste poison. All these conditions are there are a lot of
Plasma
data getting
crisis.
generated in recent days. At least last 5 years, a lot of data coming up with Flex. So plasma exchange has almost replaced Mars. We are not doing Mars. I haven't seen a Mars at any time so far. But plasma exchange we are doing almost every day. So selected patients, not every DCLD will undergo plasma exchange. It's whenever there is an acute worsening and there is a release of cytokines, the cytokines, DAMs, PAMs, all those things will be removed by doing a plasma exchange and will promote liver regeneration. That's a basic concept of doing plasma exchange. It's gaining a lot of data.
Okay. How to treat hepatorenal syndrome, Balaji?
Sir, by IV infusion of albumin along with norepinephrine, sir. The norepinephrine dose will be 0.7 mg per kilogram along with IV.
You always sit in ICU, not treat with the hepatorenal syndrome. Don't give any drug, oral drug.
Octreotide can be given, sir.
Octreotide.
Along with midodrine. Midodrine also can be given in case of HRS.
Yes, midodrine and clonidine.
Clonidine.
Yeah, midodrine. How does the midodrine acts? How does the clonidine acts? Midodrine is an alpha agonist, alpha 1 agonist. Clonidine is alpha. Centrally acting alpha 2. Alpha 2 agonist. This is alpha 1 agonist, right?
Yes,
that is
sir.
alpha 2 agonist. In the central. Thereby, both are constricting this splanchnic.
Splanchnic vessel. As a result, there will be increase in the effective circulatory volume, sir.
Yeah, because the increase the constriction and the effective circulatory volume increase, thereby the postural hypertension is decreased. So patient improves clinically with the midodrine and the clonidine. And that can, even though clonidine is an antihypertensive drug, by alpha 2 effect, it increases the vasoconstriction, the splanchnic vessels, right? Okay.
Okay, sir.
As a refractive, how to treat the refractive ascites?
The refractory ascites can be treated with large volume paracentesis along with IV albumin infusion,
How much
or
I will
else alpha pump insertion can be done, or else tips can also be done in case of refractory
how much
ascites, sir.
albumin you give for 1 liter of acid if you aspirate?
Sir, for 1 liter, I used to transfuse 8 gram of 8 gram of human albumin for 1 liter, sir.
1 liter, right? Okay,
Yes,
what is the
sir.
commonest complication? Large volume paracentesis, commonest complication?
Sir, post paracentesis circulatory dysfunction, sir.
1 to
Two.
hyponatremia.
Hyponatremia.
Very common. Before that, you have to be starting the IV fluid with the normal saline one side, then you take your fluid the other side. Otherwise, one, hypotension is very common. Two, hyponatremia is very common. Patient go for encephalopathy due to hyponatremia. You have to be very careful not to develop hypotension, not to develop hyponatremia when you do a large volume paracentesis. Okay,
Yes,
that
sir.
yeah, of course you have to transfuse albumin for every 1 liter. You have to give 7 to 8 grams of albumin, right?
Yes, sir.
Right. Good. Good. 10 o'clock, 10:30 time now.
38 channel.
Yes. Yes, our organizer. We will now open to the organizer.
Yes,
Introduction.
yes, sir. Yes, sir. Thank you, sir. Thank you very much, sir and madam, for enlightening our students about it. And many of the students have been watching. And so over to Saravanan, sir. Saravanan, sir.
Yeah. Yes, sir. As usual, Parandaman sir fired with the questions from starting from the basics to the advanced level also. And Alakame madam also complementing this information what shared by Parandaman sir. I think it's more useful for all the postgraduates. I think I should appreciate Balaji for wonderfully answering almost 75% of the questions.
Yeah, yeah,
It goes to, the credit goes to the teachers of their department who is really preparing the students very well and really facing the examiner like Parandaman sir.
yeah.
Really appreciating Balaji for wonderful preparation
Thank
as
you,
well as the
sir.
teachers also, as well as teachers also. Really, thank you, Alagame madam, for wonderfully the information about the latest updates as and clinical tips of management of the patients with chronic liver disease. And as usual, Dr. Parandaman sir was clearly talking about what is expected on the day of examination for a postgraduate, what to commit, what not to commit, and how to give an explanation was clearly explained by Dr. Parandaman sir. He's been examined for many, many decades. So he knows what are the problems or mistakes done by the postgraduate, especially postgraduate at MD level, which is not supposed to be made by them. And it's been highlighted by the Parandaman sir. Really, thank you, sir, for being the faculty for this evening, and Alagami madam also for wonderfully discussing on the practical tips on the management of chronic liver disease. Thank both of them for this wonderful discussion.
Thank you. Thank you.
Appreciate Balaji also.
Thank you,
Thank you, sir.
Balaji. Congratulate Balaji for wonderfully answering. As Sarva sir said, you're almost 70% of the questions you are able to answer with very nicely. Madam was very vigilantly or vigorously and currently asking all the questions, and I learned a lot from Madagami madam. Thank you very much, madam. Very nice your discussion. And I thank Dr. Nataraj. Taken the effort to organize. He was keep on giving reminders. Sir, this is the day. This is the day. Please come like that. So that's really nice. And Dr. Saravana is doing good things. This is the first time actually attending. So many years it's been conducted, and this is the first time I log into this forum.
Yes, sir. Yes, sir. I know. I know you are the first time you are joining today. Today is the first time.
Yeah. Yes, sir. Thank you very much. You're
Since
wonderful.
Parandaman sir was our teacher here and he was the first chief of our medical college.
Yes,
Tiruvallur Medical College, he wanted to participate in this. Thank you very much, sir. Thank you very much for your wonderful this thing, sir. And from Alahami madam also, you have learned a lot of new things. What is the update? And madam, thank you, madam, for your sharing your knowledge.
Thank you for the invitation, sir. Thank you so much. Thank you, sir.
Right, madam. Thank you, madam. Thank you very much.
Thank you,
Thank you,
everyone.
sir.
Thank you.
Good night.
Yeah.
Thank you, sir.
Thank you, Narai sir.
Good night, sir.
Madam,
Good night, all of you.
thank you, madam.
Thank you, sir.
Bye-bye.
இப்ப இந்த இங்க இது எப்படி